And let me introduce the first speaker, Professor Neelika Malavige, Head of Dengue at DNDi, Drugs for Neglected Diseases Initiative, and also Professor at the Department of Immunology and Molecular Medicine at University of Sri Jayewardenepura in Sri Lanka, where she has a research focus on dengue therapeutic targets, especially on mediators for vascular leak and the role of antibodies in disease pathogenesis and the correlates of protection in dengue. So today, Neelika will give a talk on epidemiological and clinical and immunological risk factors of severe dengue. So please, Neelika, go ahead.
Thank you, Peter, for the introduction and inviting me to talk today to this audience. First of all, I have to say that I'm having the flu, so if I'm coughing from time to time and sounding a little bit croaky, please do excuse me. Just to, I'm sure all of you listening here do know about dengue, but I thought I'll just start with dengue epidemiology. As you know, dengue is seen in the tropics and subtropics where the Aedes aegypti mosquito circulates. And over the past 30 years, the global infections have risen from 23 million to 104 million, and the age-stratified deaths and deaths have also increased about 109%, which is a huge increase. And when you look at this figure, which is incidence versus mortality rates, you will see that there is a difference in incidence versus mortality rates, with mortality rates being higher in Asia, although the incidence is the same in Latin America and Asia for the incidence. So there could be several reasons for this. Of course, the differences in mortality, which we can talk about later. But of course, if we ask the question, why has dengue increased over the years? Climate change would be an obvious answer. With the global temperatures increasing, the vector competence increases, and the geographical spread of the vector increases. That is one reason. But are there any other reasons? So dengue-like illness was initially described in 992 in China, and was first isolated in 1943 in Japan. And in the 1940s and end of 1950s, dengue was a very sporadic illness, and the countries which were reporting dengue only had one circulating serotype, although there are 4 dengue viruses. With time, some countries started seeing more than one serotype, and the first outbreak of dengue hemorrhagic fever was reported in Manila in Philippines. That is from 1953 to 54. And with time, the number of countries having all 4 dengue serotypes circulating increased. And as of now, you can see that most of the countries in the tropical and subtropical regions do have all 4 dengue viruses co-circulating, which means that people get infected with several different dengue viruses throughout their lifetime, experiencing secondary dengue, which is a risk factor for severe disease. Now, over time, things have changed, and Thailand is one of the countries which has been experiencing dengue for a long time. And initially, when it first started experiencing dengue, the case fatality rates were over 10%. And this is something that has been experienced in all countries, irrespective of the time when dengue was is initially introduced. The case fatality rates are around 10%. And with better understanding of the disease, about how to detect the fluid leakage and how to actually administer fluid, the case fatality rates had slowly declined. And currently in Thailand, for instance, it's less than 0.1%. And those days, until quite recently, dengue was a predominantly childhood infection in Thailand. It is still a predominantly childhood infection in many countries. However, in many Asian countries, possibly because of the change in demographics of age, you see more and more cases in adults as well. Now in Thailand, as I said, the mean age of the population has gradually increased over time. However, you can see that the increase in the age of dengue hemorrhagic fever doesn't necessarily follow the same patterns of the increase in the median age. And over time, although earlier dengue hemorrhagic fever was basically a childhood illness, now dengue hemorrhagic fever is seen throughout all age categories. And this is the case again in most Asian countries. So with this change in epidemiology, just to summarize what I've been talking about and to describe what it means for the future and the challenges faced, the climate change and increasing vector competency leads to geographical expansion of vectors, which leads to increasing incidence in dengue in endemic countries, spread to new geographical locations. So for instance, Europe had a particularly hot summer this year, and dengue was reported in France and Italy. And with more intense circulation of all 4 dengue viruses, people get infected several times with these viruses and therefore are at risk of more severe disease. And because of this change in age of infection with the virus, there are more infections in adults of reproductive age and old individuals, which means dengue does occur in pregnant women and older adults with comorbidities, leading to severe dengue. And just to take you through what happens when you get dengue, so the Aedes aegypti mosquito and sometimes the Albopictus mosquito injects the virus into the intradermal capillaries, and it infects keratinocytes and many other cells in the tissues, in the skin, monocytes, macrophages, ILC2s, dendritic cells, hepatocytes. I mean, it disseminates around. And after this intense period of viremia, where many of these immune cells produced many types of inflammatory mediators, the patient may proceed to the recovery phase, where there is no fluid leakage, and in such an instance, the person is said to have dengue fever. But in some proportion of individuals, these inflammatory mediators act on the endothelium, causing endothelial dysfunction, resulting in fluid leakage. This fluid leakage causes pleural effusions, ascites, and so on, which I will describe soon. And so the vast majority of people who are actually infected with the dengue virus develop asymptomatic infection. Some do develop symptomatic infection, but not severe enough to go and be reported as dengue fever. And it is a minority who actually develop dengue hemorrhagic fever or if untreated, dengue shock syndrome. And studies have shown that around 25% of dengue infections to be symptomatic. However, this changes with age. The likelihood of symptomatic infection increases with age. So for instance, in children less than 10 years of age, it was shown that 7% of infections were symptomatic versus 8 to 11% by 20 years. And in adults, although these percentages have not been calculated, it is predicted that adults are more likely to have symptomatic infection. So one of the questions is, are we seeing a higher number of dengue cases due to increase in symptomatic infection as more adults are infected? And coming to the risk factors, which is specifically because of more infection in adults, is the clinical risk factors for severe dengue is diabetes, cardiac disorders, asthma, obesity, and basically metabolic diseases. So obesity, hypertension, metabolic disease, these type of non-communicable diseases are on the rise in Asia and I believe everywhere globally. But specifically in South Asia, there is a very steep increase in these diseases. And of course, these are most important risk factors for development of severe dengue. And if I just show some data from Sri Lanka, although dengue has exponentially increased in Sri Lanka, this increase, when you compare from 2000 to 2012 and 2018, this increase has been basically in the old age groups. And just to show you the incidence increase in the prevalence of diabetes in the Western province of Sri Lanka. So it's the Western province that actually reports 55% of cases of dengue, actually more than 50% of cases of dengue are within the Western Province in Sri Lanka. And just to show you, over the years from 1990 to 2015, the prevalence of diabetes has increased exponentially. And by 2015, 27.6% of the population in the Western Province have diabetes. That's a huge proportion. And in other countries in Asia, obesity has increased in both adults and more so in children. So these are important risk factors for severe disease. And so because of these epidemiological risk factors of increase in the prevalence of these non-communicable diseases, do they actually also lead to an overall increase in symptomatic dengue? In other words, do they tip the balance of 1 in 4 ratio of symptomatic dengue towards, say, 1 in 3 or something like that? And do they predispose to severe dengue? More the proportion of people developing severe dengue in these countries. Now, another complication that occurs with the increasing age of dengue is maternal dengue. And this large study done in Brazil from 2007 to 2012, collecting data over 5 years, has shown that dengue increased the risk of maternal death by 3 times, and dengue hemorrhagic fever increased the risk of maternal death by 450 times when compared to mortality of pregnant women without dengue. So that's a huge increase. And the study from India also showed that the maternal deaths were quite high, and a lot of 34 had either severe dengue or dengue with warning signs. And there have been numerous studies showing that dengue in pregnancy was associated with adverse maternal and fetal incomes like stillbirth, miscarriages, intrauterine growth retardation, meconium aspiration, and so on. So coming to risk factors of severe dengue, because I think most people who are listening from the US are familiar with COVID, some of the risk factors of dengue are very much similar to the risk factors associated with COVID. But there are certain unique factors, risk factors for dengue, such as a secondary infection and certain viral serotypes. So for instance, dengue 4 serotype, it has a tendency to cause milder infection than the other serotypes. Now coming to the disease classification and understanding what severe dengue is. So in 1997, the classification was a classification of dengue fever and dengue hemorrhagic fever. And dengue hemorrhagic fever was when individuals had thrombocytopenia with evidence of plasma leakage. However, in 2009, the WHO changed this classification and had now revised it with dengue with warning signs and without warning signs. And severe dengue was classified as severe plasma leakage, severe bleeding, and severe organ involvement. And these warning signs were defined so that it would help to sort of predict those or identify patients who are more likely to develop severe disease. However, recent analysis published in Genomic Medicine showed that these clinical warning signs had a poor sensitivity and specificity for predicting progression to severe disease, and more so in adults, that these warning signs were a poor predictor. And as far as I know, the WHO is thinking of revising these classification because it is not done so for a long time. I'm sure all of you are aware with clinical presentation of dengue, but I put this up so that with the flu outbreaks in all countries, I know many countries are having outbreaks due to influenza, RSV, and COVID, but in dengue endemic countries, apart from COVID, influenza, and RSV, we also have the added complication of dengue, which very much presents like any other flu-like illness, with fever, lethargy, muscle pain, headache, sore throat, which does occur in about 25% of children, and GIT symptoms with laboratory features of lymphopenia, thrombocytopenia, elevated liver enzymes, and elevated CRP, although it's not usually more than 50. So based on clinical presentation, especially during early illness, it is almost impossible to differentiate dengue reliably from these other illnesses such as COVID and flu that I just described. Now, coming to why people actually develop all these complications in dengue, whether you call it dengue fever, dengue hemorrhagic fever, or severe dengue, the main reason why you do develop all these complications and clinical features is this plasma leakage. The plasma leakage leads to pleural effusions or ascites, and if very large, leads to respiratory distress. It also leads to hypertension and leading to poor organ perfusion, and liver dysfunction is a common occurrence in severe dengue, which may occur not just because of plasma leakage, but also because of direct infection of the hepatocytes, and also dysfunctional immune response and the cytokine response leading to liver dysfunction. And this leads to acute liver failure and hepatic encephalopathy. And hypertension leads to further lowering of blood pressure, leading to shock and cerebral hypoxia. And the hypertension also diverts blood flow from the uterine and in gastrointestinal mucosa, and along with coagulation abnormalities, platelet dysfunction, and endothelial activation, leads to gastrointestinal and vaginal bleeding. And vaginal bleeding can happen without, even in dengue fever, in a very severe manner, without plasma leakage because of coagulation abnormalities. Now, what causes plasma leakage is one of the most important things, and there are viral factors like the virus NS1 antigen and the viral genotype with certain mutations. Host factors like immune status, primary versus secondary dengue, and comorbidities are important. So this is a large study from Vietnam showing that the viral loads were highest for dengue 1. However, the risk of hospitalization and severe disease was highest with dengue 2. This is despite dengue 2 having low infection with the dengue 2 having lower viral loads than with dengue 1. And this is another large study done by the OCRU in Vietnam, led by Cameron Simmons, which shows that in patients with primary dengue had higher viral loads than patients with secondary dengue, and also had higher NS1 antigen loads than those with secondary dengue. So basically, although severe dengue is more frequent in secondary dengue infections, patients with primary dengue did tend to have higher viral loads and higher NS1 antigen levels. However, what was shown that rather than just the viral loads at the time of presentation, what is important was the delay in clearance of the virus in patients who progress to develop a dengue hemorrhagic fever. And apart from the virus, the host immune response is extremely important in the outcome of dengue infection. And these inflammatory mediators are increased very early in infection. So within day 1, 2, and 3, this is way before the patient develops vascular leak or enters the critical phase. These inflammatory mediators like such as IL-1RA, CRP, IP10, IL-8, and many more are elevated in those who progress to develop vascular leak. This is way before they actually do. And in another study done by Ashley St. Jones in Singapore, looking at mast cell products like chymase, she also showed that serum chymase levels were significantly higher during early illness compared to those who did not develop vascular leakage. And one of our studies comparing cytokine storms in dengue and COVID, in that we showed that IL-10 levels were significantly higher in patients who progressed to develop dengue hemorrhagic fever compared to patients who did not require admission or just had dengue fever. So patients who progress to develop dengue hemorrhagic fever appear to have a dysfunctional immune response during early illness, leading to immunopathology and delayed clearance of the virus. So NS1 actually, how NS1 causes vascular leak is it does so by many mechanisms. It directly disrupts the glycocalyx of the endothelium. It induces cytokines and inflammatory mediators that cause disruption of tight junctions. This is by acting through TLR4. And it also induces MMP9 secretions of PBMCs. And it also contributes to thrombocytopenia by platelet activation and enhancing aggregation. However, one of the important risk factors of dengue is secondary dengue, of severe dengue is secondary dengue. So what is the evidence and why is this the case? And there are many studies over and over again, starting from the early 1970s, coming from Brazil, which showed that a secondary dengue infection was significantly associated with severe dengue. And this is one of the issues that was faced by the Sanofi Pasteur vaccine, where the vaccine in low transmission settings, where the vaccine was given to individuals, seronegative individuals, the vaccine actually acted like a primary dengue infection and then induced severe disease in a more secondary like dengue infection. And this is why later the guidelines had to be reversed to give the vaccine to dengue seropositive individuals. And so how do these antibodies actually cause severe disease? One thing is by these immune complexes binding to cells which have Fc gamma receptors. So more and more cells are infected by these immune complexes rather than with the dengue virus alone. So there is enhanced infection of these immune cells during secondary infection. Also, because of these immune complexes, there is complement activation, which again is a feature of severe dengue. However, one of the most extensive studies done by Eva Harris in Nicaragua, she has this very beautiful longitudinal cohort. They have shown that primary and secondary dengue infections were equally likely to be inapparent. So it's not just the presence of these antibodies for the previous serotype that leads to secondary dengue. The specificity, whether they are broadly cross-reactive or serotype specific, and the ability to, the functionality of the antibodies, such as the ability to activate complement, induce phagocytosis, and ability to activate NK cells matter. And Ashley St. Jones has done a lot of work on mast cells. Mast cells themselves are infected by the dengue virus directly, leading to mast cell degranulation and releasing products like chymase, tryptase, PAF, and leukotrienes, which cause vascular leakage. But apart from that, the pre-existing antibodies, when they form immune complexes with the virus, cause mast cell degranulation through Fc gamma receptors. So there is more mast cell degranulation during secondary dengue infection. And during secondary dengue infection, there is also more activation of NK cells, which recognize the virus bound to Fc receptors. So coming to how do we get out of this mess? Because as it is very evident, the incidence of dengue is increasing significantly globally, and it's also expanding in several geographic locations. And this is a picture from Sri Lanka in 2017, which we experienced the largest outbreak. So this is a medical ward which is managed by around 4 nurses and 3 doctors at any given time. And so all these patients have to be monitored, their blood pressures taken every 2 hours, their blood counts done 3 times a day, urine outputs checked every 2 hours, to find out who is going to be leaking, who needs to be there, have their fluids regulated, and so on, which is an impossible task. So I think it's very evident that we need drugs to prevent progression to severe disease, severe dengue. And so there have been many clinical trials that have been carried out for antivirals and host-directed therapies in the past. And currently there are 2 antiviral trials undergoing, the Janssen drug and the Novartis, and also ketotifen done by Ashley St. Jones with the host-directed therapy, which we are awaiting the results. DNDi, realizing the importance of this very neglected disease and the impact that it causes in endemic countries, the burden of the infection on the healthcare systems, have included in their portfolio in December 2021. And the idea is to discover repurposing drugs as an antiviral and host-directed therapies to find deliver a treatment solution for dengue. And so the idea is to have a direct-acting antiviral and a host-directed therapy. And this is some data from our lab showing the viral curves with time. And as you can see, the viral loads decline very rapidly. So there is a very short time period for the direct-acting antivirals to act, which means that you have to treat early, at least before day 4 of illness. And as I mentioned earlier, the inflammatory mediators are also increased very early in illness. And it is not just the virus, it is the inflammatory response also that contributes to severe dengue. So the idea is to have a direct-acting antiviral and a host-directed therapy as a treatment solution. And how we are planning to do is, the first time this dengue, I believe this dengue alliance has been formed to find this treatment solution for dengue. So it's a South-to-South partnership, which is co-created, co-owned, and co-funded by the partners. And these are the 5 partners, along with DNDi, which are partners of this dengue alliance. Mahidol from Thailand, THSTI India, IMR Malaysia, Fiocruz Brazil, and UFMG Brazil. And so currently the in vitro testing for antivirals have been completed, and mouse studies are ongoing. Host-directed therapies, the preclinical studies are under discussion. So we are in the process of establishing a clinical network to provide this treatment solution for dengue along with our partners. So thank you for listening, and I'm happy to take any questions. Thank you.